The topic we are going to discuss today is juvenile idiopathic arthritis. It's a long topic, so I have divided it in two parts. We are going to discuss the first part today. JIA is by far the most common systemic disease associated with childhood anterior uveitis, with the prevalence of about 1 in 1000. It is defined as arthritis of unknown etiology that begins before the age of 16 years and persists for at least 6 weeks. Up to 50% of children affected have persistently active disease after 10 years. It may result from exposure to one or more unknown antigens in genetically predisposed individuals. Immunomodulatory treatment should be considered early in the course of JIA because it is the most common systemic disorder associated with childhood anterior uveitis. Now, the patient presents with arthritis. JIA is classified by the International League of Association for Rheumatology ILAR 2004 revision according to the extent of joint involvement during the first 6 months. So the first and most important type is oligoarticular, and it is the most common form. 4 or fewer joints are involved. The knees most common, followed by ankles and wrists. Girls are affected 5 times as often as boys, with a peak age of onset around 2 years. Some patients subsequently develop polyarthritis. About 75% of children are ANA positive, a strong risk factor for uveitis, which is common, affecting about 20% of children in this group. The next group is polyarticular, which is rheumatoid factor negative, and it affects 5 or more joints, typically both small and large joints. Symmetrically, the female-male ratio is about 3 to 1. The disease may commence at any age throughout childhood. Systemic features such as fever and rash may occur but are milder than in systemic onset. About 40% of children are ANA positive. Uveitis occurs in 5 to 10% of the cases. Then is the polyarticular rheumatoid factor positive. It again affects 5 or more joints and may resemble adult rheumatoid arthritis. There is a very low risk of uveitis in this scenario. We have to compare the frequency of uveitis, which is 20%, then 5 to 10%, and then a very low risk. Then comes the systemic type, which is also known as Still's disease. Systemic features such as fever, episodic erythematous, maculopapular rash, lymphadenopathy, and hepatosplenomegaly may precede arthritis. Disease occurs with equal frequency in boys and girls and may occur at any age throughout childhood. The majority are negative for ANA and uveitis is rare. After that is enthesitis related, which is inflammation of the connective tissue where tendons or ligaments attach to the bone. Psoriatic and undifferentiated are 3 other forms under the ILAR classification. The first 2, which is enthesitis and psoriatic, have a relatively high risk of uveitis, but risk in the latter, which is undifferentiated type, is usually very low. The most commonly affected joint is that of the knees, and it presents as swelling. Uveitis is severe and it can present with posterior synecdoche and in long-term cases with cataract. Now, anterior uveitis is a key cause of morbidity in JIA. It is particularly common in oligoarticular JIA, which is also the most common one, and relatively frequent in several other types. Progression to blindness has been high in the past, but shows a declining trend in the recent years, associated with improved screening and management. Arthritis usually antedates the diagnosis of uveitis. Presentation of the uveitis in JIA is particularly dangerous because it is invariably asymptomatic and must generally be detected by screening with slit lamp examination. Even during acute exacerbation with +4 aqueous cells, it is rare for patients to complain. Although a few uh, report an increase in vitreous floaters, often uveitis may not be suspected until the parent recognizes complications such as strabismus or an abnormal appearance of the eyeball due to band keratopathy or cataract. Injection is usually absent even in the presence of severe uveitis. Inflammation is chronic and non-granulomatous. Both eyes are affected in 70% of the cases, and there is symmetrical severity of inflammation. During acute exacerbations, the entire endothelium shows dusting by many hundreds of cells, but hypopyon is usually absent in these cases. Posterior synecdoche are common in long-standing undetected cases. Band keratopathy and cataract are common in severe cases. Other serious complications include glaucoma, which is common, amblyopia, maculopathy in the form of cystoid macular edema and epiretinal membrane, cyclitic membrane, and phthisis. Now, in about 10% of the uveitis is mild, with never more than +1 aqueous cells and persists for less than 12 months. About 15% of the patients have one attack lasting less than 4 months. The severity of inflammation varying from +2 to +4 aqueous cells. In 50% of the cases, the uveitis is moderate to severe and persists for more than 4 months. Lastly, in 25%, the uveitis is very severe, lasts for several years, and responds poorly to conventional treatment. The presence of complications at initial examination appears to be an important risk factor for development of subsequent complications, regardless of therapy. Good visual outcome can be achieved by early recognition and rapid referral to a specialist for immunomodulatory therapy. So, I will be discussing the investigations and treatment in the next lecture, since this is getting longer.